All right. Thank you all for the opportunity to present. My name is Nick Mouawad, and I'm a vascular surgeon up in Michigan. And I'm going to present an interesting case, tale of two lesions with a new device that I quite like. So the regular vascular patient, 67-year-old male, hypertension, has a rather remote history of tobacco use, Rutherford class 4 with rest pain, and a task C lesion. He's had no previous interventions, and his ankle brachial index is 0.18, so severe arterial insufficiency at rest. Here you can see the left superficial femoral artery. Clearly in the distal SFA there's a lesion, and even more distal at the level of the adductor hiatus there is a popliteal occlusion, a CTO. A lot of collateral vessels. This is reconstitution at the P2 segment, and I'll show you the runoff, which is clearly the most important. Infragenicular vessels appear satisfactory. As you can see, the anterior tibial and PT fill quite nicely. Perineal reaches the ankle mortise without any concern. There is filling to the plantar vessels of the foot, as you can see over here, and there is a complete plantar arch. Interestingly, despite all that, patient has rest pain. I mean a really low ABI for just a short segment chronic total occlusion of the distal pop. So there's two lesions here. Goal is clearly to manage them due to the critical limb ischemia and the Rutherford class 4. Approximately, like I said, in the SFA or the distal SFA, that high-grade stenosis in the CTO in the popliteal lesion. I elected to treat the proximal SFA with drug-coated balloon technology, and the chronic total occlusion of the pop started shifting more to using a scoring catheter called the Flex Dynamic Scoring Catheter. The popliteal lesion was around 5 millimeters, the length was 60 millimeters as you saw, and for either treatment modality I did not pre-dilate with a regular balloon. So just to talk to you about this Flex Scoring Catheter, it's a vessel prep device. What you plan on doing initially is to cross the lesion initially, and it's a pullback technique. It's 6 French modality, and you can use it either on 014 or an 018. I prefer the 018. I feel that you get more coaxial support in that regard. There's 2 treatment lengths again. A shaft length is 40 and 120. And the point is, in 3 different locations, 3 different angles, we have these atheratomes. It's a scoring sharp device to basically score the lesion, ultimately to prepare the device in which you can deliver the drug-coated balloon technology, the paclitaxel, whichever excipient you want to use, be it urea or polysorbitol. So these microincisions are controlled. They are at around 1 atmosphere and of a height of 0.01 inch. And again, they're at 3 different angles, so 30 degrees at each part of the lesion. So what you do is you cross the lesion, pull back, score the plaque, resheath the device, pass it back down again, turn it 20 degrees, 30 degrees, and this way you can have multiple different micro incisions. 2 quick studies here to discuss. This was a trial that was set up in Europe. 24 operators, 15 hospital systems, and basically the Flex catheter is effective in recanalizing CTOs with very low levels of vessel dissection. And as you see, there was a luminal gain of over 30%. Very minimal provisional stent use for bailout technique, and then the lesions were mostly or relatively calcified. Again, we use it as a vessel prep device, so almost everybody was receiving drug-coated balloon technology. Now, everybody loves the trials because they're all set up that way, but we also evaluated them in real-world data, over 83 operators, over 50 health systems, and again, you can see there's a satisfactory amount of luminal gain. We prepared the lesion for drug-coated balloon technology, and flow-limiting dissections, embolies, and perforations, which are the worst thing that we don't want to see, we had 0%. Okay, so the Flex is safe and effective in calcium, and it allows you to be able to deliver the drug-coated balloon or paclitaxel. Here you can see on the screen right that the device, in fact, is now in the below-knee popliteal artery in the P3 segment, and you unsheath the device, and then you do a pullback technique and take across the lesion that you want to treat. Technically speaking, at this point, you resheath it, you advance it, you turn it, and then you unsheath it and pull it back yet again. And you do that 3 or 4 different times. Ultimately, you exchange that again for your drug-coated balloon, and you can treat that. This is the Flex technology without the use of any post-balloon. And so you can already see that you've had satisfactory luminal gain, and in fact, you've opened up the popliteal segment. Now, following that, if you use drug-coated balloon technology, or whatever balloon you want to use, I'm a very big fan of DCBs. You can see here you don't have to crank up the balloon to nominal pressure. I tend to not do that. My goal is to basically have satisfactory contouring of the vessel. I find that when you go up to nominal pressure, you tend to have more dissection. So, but in this case over here, we inflated it to good contouring, held it for 3 minutes as per the IFU for impact, and there was minimal, I don't know if you can see that again, I'm sorry, residual stenosis. No dissections, emboli, perforations that I've seen with Flex or DCB. Most importantly, we'll discuss it a little later on, lower radiation, faster to do. The proximal SFA lesion, as you see, was treated with impact only. Okay, I do see a small little dissection, but it's non-flow limiting. And then the distal lesion in the pop with the P1, P2 segment there, you can see that no dissections or emboli, and you see nice filling of the infragenicular trifurcation. And then clearly you want to make sure that the tibials down the foot look okay, and you can take my word for it, but they do. And the perineal also fills, and then you can see the plantar arches again fill quite nicely and complete the arch in totality. So without vessel prep, as you saw in this kind of case control segment in the SFA, without pre-dilatation, the angioplasty, we did have a dissection that was non-flow limiting, just with the balloon angioplasty. With vessel prep, again, we were able to score the lesion. First of all, cross the CTO, score the lesion, get the luminal gain that we needed, and then ultimately assist in delivering the drug-coated balloon technology and let the paclitaxel do its work based on whichever excipient that you want. No dissections, no stents, which is what you want to avoid if at all possible. I found that it saves time, radiation exposure, very easy to use, 6 French platform. Thank you so much. Any questions?
So why not just use the flex catheter on that SFA lesion as well?
Oh, so absolutely you could. What we were doing, the reason why we didn't here was we wanted to basically show 2 different modalities in the same patient. That was really it. It was kind of our own case-controlled randomized trial. But otherwise, I would have absolutely done that.
Because you end up with a dissection there. And
yeah, I completely agree. We wanted to just we wanted to show the difference. Hey, you know what? We prepared the vessel appropriately for delivery of the drug with a flex catheter at one point, and the other one without a flex catheter, and we found that you get more dissection. So the alternate discussion is now, so you know what? Why are you using a flex catheter? Why don't you use a scoring balloon? Well, so this was the whole particular reason. In the scoring balloon, you have a lot of the balloon effect that cause more dissection in order to kind of push through or break through the plaque with the scoring mechanism. Versus in this scenario, you're just causing a micro dissection or micro incisions in order to deliver the drug into the intimal layer.
Any experience with this device in venous CTOs?
No. Well, I mean, I can't discuss it. No. But I think there'll be good application. Let's say even in dialysis segments, but for these purposes, no.
Thank you.
Thank you so much. I appreciate it.